So today we'll talk about impingement of the shoulder. So when we'll talk about rotator cuff disease. We'll start out with impingement, and then we'll go through some of the pathogenesis of rotator cuff injury, and then we'll talk about tears and other pathologic changes of the tendons in later talks. So looking at impingement, it can kind of be divided into four different overall types. Acromial impingement from the acromial process itself, disease at the acromioclavicular joint, then anterior impingement, it's also called primary core cord impingement, and then internal impingement, which is also called posterior impingement of the shoulder. So the primary impingement is really around the acromion. That was really popularized by Neer, and this was a well-known paper in 1983 where he talked about three different stages looking at the changes within the supraspinatus tendon that occur from the mechanical irritation of bones abnormally rubbing against the tendon. Initially you get edema and hemorrhage. That can go into fibrosis and tendonitis, and then you can get spur formation and rupture of the tendon. To evaluate the anatomic risk for impingement, and again, that's what we're talking about here is bony impingement, where there's not adequate space along the course of the rotator cuff tendons for normal function of the tendons without having traumatic irritation of the tendon from the bones. So at one type is a type 3 acromion. We'll talk about that in a minute. You can also have anterior sloping of the acromion, abnormal lateral downsloping, inferior placement of the acromion with respect to the distal clavicle, and then you can also get impingement not so much due to abnormalities of the bone, but abnormalities of the tendon and muscle junction, which we'll talk about. Then we can get impingement at the acromioclavicular joint. These are usually due to osteophyte and callus from degenerative disease of the acromioclavicular joint. You've all seen these. We'll just go through them. So the typing of the acromion, this was originally typed by Bigliani using the outlet view on plain films. The oblique sagittal view is similar, but not exactly the same as the outlet view on x-rays. And we can use a similar typing. A type 1 would be a relatively flat acromion in the sagittal plane. A type 2 is a general curve of the acromion, where the space between the humeral head and the acromion is pretty much equidistant. And then there's a type 3 acromion, where you have an anterior hook on the acromion, either from congenital, which we're seeing on the left, or an acquired osteophyte, which we're seeing on the right. So this area here is an acquired osteophyte. The normal shape, the original shape of the acromion was here, and this is a developed osteophyte, probably due to traction from the cocoacromial ligament that inserts along the acromion in this location. These abruptly narrow the space between the acromion and the humeral head and can traumatize the supraspinatus tendon and the space in between. So this would be considered high risk for acromial impingement when you have a type 3 acromion. Here's another example of an acquired type 3 acromion. Here you can see the inferior osteophyte, which is narrowing the space, and we can see some abnormal increased signal intensity within the anterior margin of the supraspinatus tendon underneath it due to the trauma from impingement. The other thing that you can get that is associated with increased risk is eburnation. Notice that this acromion is neither downsloping nor much of an osteophyte. What we have is a very irregular inferior surface, but this is indicative of trauma irritating the bone in this location, and this also has increased risk. And this kind of trauma may have been from prior injury, from whatever, but this irregularity of the inferior surface is also thought to increase the risk of irritation of the underlying supraspinatus tendon and producing impingement. In this particular case, distally here on the T2 weighted image, we can see fraying and partial tearing of the acromial side surface of the supraspinatus tendon here, which goes along with the impingement from the irregularity of the tendon. And on the axial images, we can see that abnormal increased signal intensity within the anterior distal portion of the tendon here. So that's eburnation, and it's kind of like, you can kind of think of a saw. When you get an irregular surface of the acromion process, as the tendon rubs up and down, if you have a smooth surface, you're not going to get much irritation. If you have a irregular surface, you can saw right through the log. So this irregular surface is an indication that you have increased risk for impingement. And here we can see lateral downsloping of the acromion, some eburnation here on these images, a lot of increased signal intensity and fraying of the superior surface of the supraspinatus tendon, a lot of edema or fluid within the subacromial subdeltoid bursa, but notice the cuff is grossly intact, but this is indicative of acromial impingement with bursitis and traumatic injury to the superior surface of the tendon. And there you can see the fraying of the superior surface and the increased signal intensity due to the tendinosis caused by the traumatic injury. Another case here where we can see irregularity of the inferior surface, some lateral downsloping, and a lot of increased signal intensity within the tendon. Also a person with acromial impingement. And here we can see a little bit of downsloping. We can see a lot of thickening of the bursal surface here. The tendon is intact, but here we have bursitis secondary to the impingement of the acromion process. And again, another patient with some impingement, a lot of fluid in the bursa, intact tendon, and again, this is primary bursitis due to impingement from the acromion process. Okay, let's see. Deshali, what do you think of this case?
The patient had scapular trauma a year ago and has persistent pain. So we have 2 coronal MR images, 2 fluid image, and pretty fat set image. And within the subdeltoid bursa, there's a loculated fluid collection. The undersurface of the acromion is irregular and there's downsloping. And the supraspinatus tendon fibers distally at the foot plate demonstrate a full thickness tear.
Yeah, so the deep fibers look intact, but the superficial fibers are abnormal here. So this is another case of impingement with bursitis and a lot of injury to the bursal side surfaces of the supraspinatus tendon, but overall the tendon looks like it's intact. There's a lot of fraying and irregularity of the bursal side surfaces. So this is primary subacromial bursitis due to impingement. Jeff, what do you think of this case?
Okay, we have a coronal T1 image of the shoulder demonstrating the downsloping of the acromion, and it looks like in the supraspinatus there's a focus of increased signal right there on the bursal aspect. I would need additional images to evaluate that.
There's a little osteophyte here with some eburnation. So this goes to abnormal trauma on the acromion process. And then you're right, this is a partial tear, probably greater than 50% thickness, primarily involving the bursal side surface of the tendon. And this is another case of acromial impingement with secondary partial tearing of the supraspinatus tendon. Okay, so so that irregularity of the surface, I think, is important. We can look at downsloping, best seen on the coronal images. Here it's very horizontal. Here we can see that there's a little bit of sloping of the acromion. And then we can see that the cortex is kind of nice and smooth. I didn't know what other term to use back in the late 1980s when we were trying to categorize these risks for impingement, so I just started using the term downsloping, and I think other people use it as well. But notice here that we don't really see any eburnation or irregularity of the surface, so this would be mild downsloping, probably mild anatomic risk for impingement, but without the secondary changes here, I think that there's probably the risk is pretty low. Here's more severe downsloping. Here we can see that there's now irregularity of the inferior surface, eburnation, some marginal osteophytes. So this patient, I think, is at significantly higher risk for developing impingement. And we can also see that there's a little insertional partial tear here out at the insertion of the supraspinatus tendon, primarily involving the dorsal side surface. There was a debate quite a few years ago as to where most of these tears of the supraspinatus tendon, whether they start on the dorsal side or the joint side surface. And Neer really popularized impingement as being a primary source of rotator cuff injury. Now that we've been able to follow these much more closely with MR, which we didn't have before the late 1980s, I think most tears really start in the substance or on the joint side surface. So most tears are probably not primarily due to an impingement process, but impingement can certainly exacerbate it and in some situations be actual primary cause and certainly can produce symptoms.
It depends on the age of the patient. Most tears, partial tears, occur in athletes, as you know, John.
Yep.
And they are bursal. In other words, a joint related.
The joint side surface.
Yeah. So as you get older, then it's either side, and most tears as you get older are actually interstitial.
Okay.
The way I understand it from the latest orthopedic literature.
Good. Thank you. Okay.
You're welcome.
Yep. And here's an example. This actually was my previous father-in-law, who was a handball player for many years and started developing shoulder pain. We can see that there's a lot of downsloping of the acromion here. The AC joint shows mild degenerative changes, but not a lot of hypertrophic disease. As we go more anteriorly, we can see marked debranation of the inferior surface with a little inferior osteophyte here, which is really impressing upon the superior surface of the supraspinatus tendon. We can see that actually the rotator cuff is intact here, but he's got a lot of subacromial subdeltoid bursitis here, and we can see this is all osteophyte here. The normal contour of the cortex of the acromion inferior cortex should go right along here. He's developed, for the wear and tear over the years, hypertrophic bone formation here, which has led to impingement, which was getting to the point where he really couldn't use his shoulder, and he certainly couldn't play handball anymore. Oops. I'll show you, I guess later on I'll show you the postoperative changes on him. He actually had an acromioplasty at this time, which relieved it, and actually in his late 70s he was able to go back to handball playing, which he had to stop after they did an acromioplasty, but we'll get to that later. Now, there's some other risk factors for impingement also. See, Jeff, did you do the last one?
Yes, sir.
Okay. Dan? All right.
Looks like we have an axial T1 and a PD fat set, and we have a osseous abnormality is a congenital variant is os acromiale, and there are, I guess, 3 types, and I think I'm not sure if it's like a meso or wait, okay.
So this is an os acromiale. You've all seen them, especially in this location. They're really quite common. They may or may not be associated with impingement, but what can happen in a case like this, we see a lot of fluid in the joint space. This pseudo-articulation can become loose, in which case there can be a lot of movement of the acromion process here, and that can actually lead to increased risk for impingement due to the os acromiale. Just remember, in teenagers, not joint space, this area of where the os develops the, what's the word I'm trying to find here, John?
Physis.
Yeah, thank you. The physis here may not close until age 21. So seeing a physis in this location, especially if you see no fluid in it, up until age 21 can be very much normal development.
Actually, it can actually go up to the age of 25 in some cases.
Okay, thank you, John. Age 25. Here's someone where the growth plates haven't completely closed yet, but they're in the process of almost closed, and this is just normal anatomy and a late teenager. So just be aware of that. See if I hit the space one more time here, I would have seen the word physis. Oh, thanks, John. You're correct. So, and as Dan was trying to say, these have different names. The different portions of the acromium. And this, you can keep this slide if you want. I generally don't use this terminology in a report. I typically say more the location and whether or not I think it's a cause of either instability or impingement in the report. Okay.
It was it either, John, so you're perfectly correct.
Okay.
That's a joke.
Thank you. Deshali, what do you think of this case?
Okay, so we have multiple coronal images of the shoulder, T1, T2, and PD fat set. And within the distal clavicle, there's a lot of bone marrow edema, and there's some fluid signal within the joint space. And then the acromion is relatively inferior to the.
Right.
So without.
Okay, so this is a congenital anomaly where the acromium, instead of being on the same plane and lateral to the distal clavicle, it actually articulates inferior to the clavicle. And I think this has a moderate increased risk for impingement when you see this kind of anatomy. Now, as far as edema, it is very common on PD fat set images to see edema on both sides of the acromioclavicular joint space. And we did a study that we published a long time ago looking at what MR findings correlate with actually having symptomatic disease of the acromioclavicular joints. And we did it in a group of Ironman athletes after a contest in Hawaii, where we imaged both symptomatic and asymptomatic Ironman, and then we also compared them to a group of not asymptomatic patients here from our population here in Southern California. And so what we found is edema around the AC joint is extremely common in both symptomatic and asymptomatic individuals. And there really wasn't a good statistical correlation between bone marrow edema in the distal clavicle and actually symptoms of the AC joint disease because it was so common in asymptomatic individuals. So that's just something to be a little bit aware of. Symptoms tend to be associated with marked irregularity of the subchondral articulating surfaces and if there is instability or displacement of the AC joint. Okay. And here we can see the acromion process, some increased signal intensity along the superior surface of the supraspinatus tendon distally in that location. And now what we're seeing here is something else that I think can be cause increased risk for symptoms of impingement. In this particular case, the acromion isn't really all that abnormal. Well, we're a little bit posterior to the articulation with the clavicle in this location. But what you see here is actually, if you follow the muscle here, the muscle actually comes all the way out to the location where we see this red arrow, where I'm pointing to here. Normally, the musculotendinous junction of the supraspinatus tendon should be right around the 12 o'clock position of the humeral head. And if we have a complete tear of the supraspinatus tendon and we have a retraction, we can measure that retraction either by trying to measure the end of the tendon and how far it's pulled back. Sometimes that's difficult, especially if you have scar in situ. So sometimes you can use a surrogate marker, which would be the 12 o'clock position and how far you measure back to where you see the musculotendinous junction. But there is an uncommon variant where the musculotendinous junction actually is more distal, which means you have muscle now in between the acromion process and the humeral head. And this, the muscle takes up much more space. In this particular case, I think you can have a normal arch, but you can have symptoms of impingement because the muscle gets impinged between the two bones. the first time I actually saw this was back around 1990, and we were doing imaging on a well-known wrestler who went around the country doing wrestling that you see on TV and so forth. He was a big guy, and you know how they are. They're more personality than they are actually wrestling. But he was a very muscular guy. But he went and he could wrestle just fine, but he couldn't carry his suitcases because when his arms were down at his side and he picked up a suitcase, he got intense shoulder pain. And when we did his MR scan, we found a lot of edema within the distal part of the muscle, and his musculotendinous junction was very distal here. So he had actually symptomatic impingement, but it was actually due to the fact that he had this anomaly. And as long as his humerus was abducted, he didn't have any symptoms. So I think this is a real phenomenon, but it's pretty uncommon. But it's just something I think you should be aware of, and that's the distal musculotendinous junction.
I've only seen one case that I operated on, John.
Yeah, really? And you did an acromial?
The patient couldn't bring his arms down.
Wow, interesting. And here's just another example where you can see the muscle extending very distally with a very small supraspinatus tendon. And you can see there's marked thickening of the muscle here. So this can be another cause of impingement. Uncommon, but something to be aware of. Okay, and the treatment for these conditions are acromioplasty. If you have an anterior osteophyte, you can go in and just remove that osteophyte. Now, the coracoacromial ligament, actually, the coracoacromial ligament shouldn't actually insert on the osteophyte. It actually should insert on the acromion process, and the osteophyte grows along it. But still, when you remove that osteophyte, you often have to sever the coracoacromial ligament. In fact, at one time, this ligament was thought to be responsible for the impingement, and it was often resected for that reason. Now, since if you think about it, the coracoacromial ligament goes from one part of the scapula to another part of the scapula. Both the coracoid process and the acromion are part of the same bone. So in reality, it's probably only a cause of impingement if you have some and abnormal anterior subluxation of the humeral head. So generally, you don't primarily try to resect the coracoacromial process, but you do have to resect any bone that might be doing the impingement process here. Now, a real risk of acromioplasty is if you remove too much bone, you can actually create an instability of the shoulder. So typically, you try to just resect the osteophyte and bring it back to the normal anatomy of the acromion process. John, do you want to comment?
Yeah. Near caused a lot of problems for a lot of patients when he wrote this article in the 80s. That became a very popular procedure, and especially when arthroscopy came about. And most people didn't really need to have surgery on type 3 acromions and rotator cuff tears. So he didn't really do many favors for a lot of people. But anyway, when you have a type 3 with a hook like this, removing that hook is very helpful. And you cannot save the coracoacromial ligament, but unless it's hypertrophied and causing impingement, sacrificing it is really not that important, except some people have reported that you get subluxation anteriorly by doing that. I don't know how real that is. I've never seen it personally.
Yep.
But you don't try to shave that acromion too much, because you'll get fractures and you'll get all kinds of problems.
Okay, so here's a situation of a patient who came in with the acromion that we see on the left. And then the patient, because they had symptoms of impingement, they then had an acromioplasty, and here you can see where they removed a portion of the acromion process. Now, actually, according to what we've been talking about, this would be a pretty low anatomic risk for impingement. As you can see here, here's afterwards, we can see now there's a lot more fluid in the subacromial subdeltoid bursa. This patient actually did not improve with the acromioplasty, but you can see where the acromioplasty occurred.
I don't really know why they did acromioplasty on this patient.
I think it was just they didn't do surgery because of the imaging. They did it just out of clinical concern. And this was kind of in the early days of MR, where I think the surgeon might not have been as comfortable with the MR findings as we may be now.
Yeah, arthroscopy of the shoulder came about just about the time that MRI came about, a little earlier than MRI.
A little bit, yeah.
And so people really didn't know that much about this area.
So here's just another patient. This is a patient who had a history of impingement, had a history of acromioplasty, and on the MRI examination we can see posteriorly, we can see where the acromioplasty occurred, but anteriorly we can see that there's still impingement with a little bit of tendinosis of the superior surface. This patient did not also improve, but I think this is because the acromioplasty was too far posteriorly and actually missed the osteophyte that was causing the impingement.
And that deltoid doesn't look so hot either.
Yeah, and yeah, we'll need to talk about the deltoid. The deltoid is a very important muscle for the shoulder, and whenever you do surgery on the acromion, you want to make sure that you don't interfere with the deltoid attachment, because it's very hard to get it to reattach properly if you actually do that. But there is a little bit of problem there with the deltoid. So that's incomplete acromioplasty. Let's see, Jeff, what do you think of this case? This is a patient who had symptoms of impingement and had an acromioplasty.
So we have a coronal T1 the shoulder demonstrating. So it looks like the distal acromion, there's a hook along the inferior aspect.
This is the clavicle here, right?
I'm sorry, it's distal clavicle. We're talking about acromion. The distal clavicle was there is that hook there, and then it looks like that there's okay, so on this image here, I'm trying to discern where the supraspinatus in this case, and I think there's mass effects, at least on the. It looks like there's. Well, it looks like there's, mass effects certainly on the supraspinatus muscle by that hook at the distal clavicle.
Here, we're actually a little bit posteriorly near where the supraspinatus and infraspinatus should be. It's a T1 weighted image because we're primarily looking at the bones in this particular case. What we see here is a very abnormal shape of the acromion. That's because this patient's had a very large acromioplasty. But what we see here is that there's a very large osteophyte in the distal clavicle, which is in a position to create high risk for impingement, which was left in place, and this patient actually has a rotator cuff tear in this area that we could see better on the other sequences. But this was a case where there was a very large acromioplasty. The patient continued to be symptomatic, in part because the primary area of impingement was actually the acromioclavicular joint, not the acromion. So in this particular case, either this osteophyte should have been removed, or maybe it would have been more appropriate to do a distal clavicle resection instead. But also you'd have to do something with the rotator cuff here. But this was just a very large acromioplasty without actually getting rid of all of the causes of impingement. So imaging can be very helpful in directing where the surgery should be.
The first thing surgeons should learn, and I made a point of it, is what not to do. And this is a case of somebody that didn't know that.
Okay. Yep. Okay. Dan, are you next?
45-year-old male with posterior shoulder pain and 4 years old acromioplasty. So we have looks like a sagittal T2 and a coronal, looks like a PD, T1, okay. So on the sagittal view, it looks like the acromion, it has this kind of anterior hook or inferior osteophyte, yeah. And on the lateral view, it looks like there's a lot of lateral downsloping of the residual acromion with eburnation of the undersurface, and there is high grade or a lot of tendinosis versus partial thickness tear of the supraspinatus insertional fibers.
I'm not sure exactly where in this particular case the acromioplasty occurred, but we can see there's still this very persistent large osteophyte here with ongoing impingement. There's a tear here. We can see the musculotendinous junction is retracted by a couple of centimeters. This is probably the distal end of the tendon, and it should be over here. If I showed the PD FATSAT or T2 weighted images, we could probably see the tear better. But this is a full thickness supraspinatus tendon tear with ongoing impingement. So this patient ended up, I think, having a resection of the impingement of the osteophyte and repair of the rotator cuff tear. We can still see that the supraspinatus muscle looks like it's in good shape in this particular patient. We'll talk more about that when we get to rotator cuff disease. And here's a case of a patient with symptoms. Here is before. This is the anterior osteophyte. This is after, where it looks like they just removed just the osteophyte itself. And it looks like it relieved the impingement process in this particular case. Okay. Deshali, what do you think of this case?
This is a coronal T1 weighted image of the shoulder. And
yeah, this was from about 1987.
So I see the acromion, and there's a moderate acromioclavicular joint arthropathy. I don't really see the clavicle on this slice. There's a little bit of lateral downsloping of the acromion.
A little bit, but what we see primarily here is hypertrophic callus at the acromioclavicular joint space. And instead of there being osteophyte coming down here, this is actually soft tissue thickening. And you see it's extending below the AC joint. It's depressing the superior surface of the supraspinatus muscle and tendon. And then if you notice, the proximal part of the tendon here has increased signal intensity right in the areas where this hypertrophic callus is rubbing against the tendon, and the distal tendon looks normal. So this was a little old lady who had a lot of pain when she was carrying her grocery bags, and we think that this was due to impingement, in this case from hypertrophic callus from the acromioclavicular joint, and not bony. Okay.
Well, sure. Large supraspinatus muscle.
What about the muscle? She's got a good muscle. That's right.
That's huge.
Yeah.
For a female, that's I don't know how old is she?
She was. I forgot her age, but she was not young. But yeah, you're right.
Weightlifter.
Jeff, what do you think of this case?
So it looks like we have three images. The shoulder looks like on the left, I think it's a T1 and
T2.
T2. There's some T2. They're all T2s.
Yeah, this is coronal.
So
these are
okay. Well, the first thing is that is a large fluid collection or overlying the superior aspect of the within the soft tissues.
Right.
It's certainly superior. It's certainly superficial to the distal clavicle and acromion. And what I'm also seeing, basically seeing significant osteoarthritis with superior. Basically, the humeral head. I mean, there's no more articular cartilage in the humeral head. It's essentially touching the anterior surface of the acromion. So, I mean, this kind of a superior ascent of the humeral head is due to, I mean, basically the rotator cuff is completely torn.
Okay. So what we see here is a complete tear. Here's the supraspinatus tendon, marked atrophy of the supraspinatus muscle. So this is a chronic tear. No cuff going between the acromion process and the humeral head. Superior migration of the humeral head, marginal osteophytes, denudation of the articular cartilages, and then we've got a lot of hypertrophic degenerative disease of the acromioclavicular joint. And this fluid coming up like this is called the geyser sign. And this is all fluid that comes out of the degenerated acromioclavicular joint space. And you can get massive cysts that come up like this in these long-standing degenerative shoulders. And it's just called the geyser sign. Here's just a case we can see coronal images on the PD fat sat, and we can see a little bit of fluid in the acromioclavicular joint space, maybe a little bit of degenerative disease. But then if we actually go to the T2 weighted image, we can actually see that there's actually hypertrophic changes here, which are actually significantly depressing the supraspinatus muscle. So it's important to have more than just fat suppressed images when you're trying to look at anatomy, because you can often obscure a lot of the details of anatomy if you just have fat suppressed images. So I just want to point this out here. So a T1 weighted image would show this. In this case, this is a T2 weighted image showing the degree of impingement that we have here on the muscle due to the acromioclavicular joint disease. And then here we can see a big osteophyte coming from the inferior, from the distal clavicle at the AC joint space. This is what it looks like on we used an experimental coil here. This was actually my father-in-law again. And we can see it's depressing the superior surface of the supraspinatus muscular tendinous junction. So there's a marked increased risk for acromioclavicular joint impingement here. On the sagittal images, we can see that osteophyte coming down and deforming the superior surface of the supraspinatus muscle here on two different cuts where that's significant impingement. And then the treatment for this is either what's called a Mumper procedure, which is basically a distal, resection of the distal clavicle to get rid of that. Here you can see where the distal clavicle has been resected. Here's his post-MR, and we can see no longer is there impingement upon the supraspinatus muscle and tendon. And then after this, he recovered in about 2 or 3 months and then went back to playing handball again. John, do you want to talk a little bit about the Mumper procedure?
It's a very old procedure, and it's used quite a bit more today than it used to be when I was growing up. That's because we didn't know much about impingements until Neer published the article. So he did help to point this out, but it didn't help in terms of a lot of surgery afterwards. But the Mumper procedure was done mainly for arthritis of the AC joint, and that cured a lot of people that had impingement of the supraspinatus tendon. And what you do is you just resect the distal half inch of the clavicle, and hopefully you don't injure the corticoclavicular ligaments. That's the main problem with this. You must be very careful not to get that far medial. But it's a very good procedure. It really doesn't limit the patient's activities much. Maybe it may decrease the function of the patient by 0 to 5%, but I don't think it's ever been measured that I know of. I've never seen a problem there. And it's very helpful. And done quite frequently in arthroscopic surgery because it can be done arthroscopically now. You don't need to open a joint.
Yep.
Although opening that area, it's only an inch incision. That's all it takes. It's very easy to do. So arthroscopy is probably more harmful than an open procedure, time-wise.
Okay, and other ways that you can get impingement also include if you have a fracture with displacement of the bones like we see here, it can change the anatomy, producing a risk for impingement, but that's really a whole other process. And here we can actually see it's forced the humeral head downward in this particular case, but that's trauma. This is another post-traumatic case where you can see a post-traumatic osteophyte here and osteophytes on the humeral head. So after trauma, you can get a lot of changes, which can be a problem. Well, let's move on to anterior impingement. Anterior impingement is really impingement of the shoulder due to hypertrophy or an abnormal location of the coracoid process anteriorly here. Now, this was an article in the American Journal of Orthopedics which stated that there are a number of normal variations of the positioning of the coracoid process with respect to the distal, the rest of the, excuse me, with respect to the rest of the scapula, and in particular, coracoid processes which are abnormally inferiorly placed and also extend posteriorly close to the glenoid can increase the risk for anterior impingement in this location. So one thing to look for, as they called it, was a chevron sign. If you actually draw a quadrilateral space here from the anterior acromion in the oblique sagittal plane down to the coracoid process to the superior margin of the glenoid and back to the posterior acromion process, that if this has this very prominent break on the undersurface like this, that's the chevron sign, and these patients may be at risk for anterior impingement. And then here's one where we can see that the coracoid process is more inferiorly placed. Here it's more superiorly placed, but I actually think that there are better signs on MR than the chevron sign. And that just shows a chevron sign. So here's a patient with anterior pain. Well, let me do this. So what I think is a better way to look at this on MR is to look at the axial images and look at the space between the coracoid process anteriorly in the axial plane and the anterior cortex of the humeral head, which we're seeing here. And you can measure that particular space. And this area, we can see that it's a little bit narrowed. There may be a little bit of deformity of the subscapularis muscle and tendon from the positioning of the coracoid process here. And this is in contradistinction to more of a normal appearance, where we can see the coracoid process is quite a ways away from the humeral head in the axial plane. So I think this is the best way to determine this. And on the PD fat-sat images, if you have true coracoid impingement, you'll often get edema within the tendon in this location as well, which I think can be helpful. So it's kind of normal on the right, abnormal on the left. And the distance here that seems to correlate with symptoms is 7 millimeters. So if you have less than 7 millimeters in the axial plane between the coracoid process and the anterior humeral head, then consider risk for coracoid impingement. Less than 5, I'm very concerned about. Now, there are several ways that this can happen. One is you can just have an abnormal. Yes?
Hi, sorry. May I ask you a question about the measurement?
Yes.
Does the degree of internal rotation affect you? You know, for example, say if they were just poorly positioned in the gantry, or does a certain degree of rotation affect your measurement or throw you off in one way or another?
Yes, it does, and I'm going to talk about that in just a minute. Good question, Shelley. the so one is the position of the coracoid process can produce this narrowing, and we'll talk about the position of the humeral head in just a minute. Good question. The other thing is, if you have superior migration of the humeral head, then the more inferior part of the humeral head tends to extend more anteriorly, and you have an increased risk for impingement as well if you have rotator cuff tear. So now, the other thing is that you can have a fairly narrow space here, but if you don't do a lot of physical activity, it may not be symptomatic. So just because you have a narrowed space doesn't necessarily mean that you're symptomatic. So now let's talk a little bit about what Deshali talked about. So we did a study looking at the effects of glenohumeral rotation on coracoid impingement that we published a couple of years ago. I'm sorry, I forgot where we published this. But what we can see, we looked at patients where we positioned them in external rotation, neutral position, and internal rotation. And what you can see here is that there's a normal prominence of the humeral head adjacent to the biceps tendon, where it normally projects out, and in internal rotation, you can get significant narrowing of the space between the coracoid process and the humeral head. So it's important to position the patient. And well, we then did a study where we looked at positioning. We always told the techs to position the patients either in neutral or external rotation. There are a fair number of patients, however, who, if they lie in the scanner for an extended period of time in external rotation, they get a lot of discomfort. So it turned out, even though we asked people to scan them in neutral or external rotation, a substantial number of patients are actually imaged in internal rotation because that tends to be less symptomatic. But you can see where you can get marked narrowing of this space when you have internal rotation. So we looked at a control group, and just what we found is that we got significant differences in measurements. Actually, this is basically a control group where we found that where we measured the angle between the biceps tendon groove, that in external rotation, it was around 90 degrees. Neutral rotation was around 56. Internal rotation tended to be around 10 degrees when we looked at these different patients. So we actually then developed a quantitative measurement for the degree of external rotation when we did this study. Now, when we looked at a control group, what we found is quite a few patients were in external rotation, but still quite a few were in neutral and internal rotation. And when we measured the difference, what we found is there was a much larger distance in external rotation, and it became narrower in neutral and internal rotation. And then here are just some measurements where we did at different degrees of rotation, and we could see the changes in the measurement. So the conclusion was that this is important to diagnose, but the degree of rotation of the humeral head has to be taken into account when you make the measurements. And what we came up with is that the key measurement turned out to be about 7 in neutral position. If you have less than 7 millimeters, then the patients were at increased risk for symptomatic anterior impingement. So that was long-winded just to say that. So let's see, who's next? Who is the last person? I think Deshali, I think you're next. What do you think of this case?
Male with evaluate a roulette rotator cuff tear, the axial T2 image. The patient's humerus is internally rotated.
Yeah, this is markedly internally rotated because you can actually see that the biceps tendon, instead of being out at 90 degrees, is really very anterior in this location. And you can see there's a lot of disease of the subscapularis tendon coming in through here. And this particular location, we're not quite in the right location to see the coracoid process, but we can see that there's a subscap tear. Now we go to the next cut up, we're at the level of the coracoid process. What do you see here?
And there the patient remains in internal rotation, and there's narrowing of the distance between the humeral head and the coracoid.
Yeah, so here we can see the subscapularis tendon. It's marked increased signal intensity where it attaches here, but we can see marked decrease in the junction there to only about 5 millimeters. This was the next cut up, and you can see where there is really entrapment of the subscapularis tendon here, and this is actually part of the transverse ligament that goes over the biceps tendon, and this location is actually almost impingement upon the biceps tendon itself and this internal rotation view. And he has got a lot of biceps tendinosis associated with that. If we go to the oblique coronal images, we can also see some tendinosis, but we can see this was a patient who really had symptomatic coracoid impingement. In this case, it was causing symptoms of both the subscapularis tendon as well as the biceps tendon. Jeff, what do you think of this case?
John?
Yes, Jeff.
Can you go back? It looks to me like that shoulder is extremely internally rotated.
It is in this particular case, extremely so.
And it's almost subluxed posteriorly.
Yeah.
Ahead.
Yeah, that's
getting lever out of socket.
Yeah, it's really an extreme internal rotation. Oddly enough, this was the only position the patient was comfortable in where they could do the procedure.
Boy, that's interesting.
Yeah, you would think this would be a most uncomfortable position. But they would not allow the tech to externally rotate the shoulder for this. Okay, Jeff, what do you think of this case?
I have an axial T2 image of the shoulder.
This is a PD.
Like PD fat set. Looks like the shoulder is in relatively neutral position, and I can see some marrow edema in the anterior portion of the humeral head, and I do see the subscapularis tendon is attached to the corner process there, but the lesser tuberosity. But yeah, I mean, this could be due to impingement. Yeah.
Okay. So here's the coracoid process here, and one thing that seems to be a pretty good correlate of symptomatic anterior impingement is if you have marrow edema and the lesser tuberosity, presumably this is due to impaction from the coracoid process here. So basically looking for anterior impingement, I still like to look for the chevron sign on the oblique sagittal images, but more importantly, I like to look at the position of the coracoid process with respect to the lesser tuberosity on the axial images and the space between the two, and most importantly, whether or not there is edema within the lesser tuberosity in this very characteristic location, which tend to correlate best with symptomatic anterior impingement. Okay. Dan, what do you think of this case?
Chronic anterior shoulder pain. We got an axial, looks like a PD and PT fat set. There is a thickening of the subscapularis tendon with increased signal, severe tendinosis with probably some partial interstitial thickness tear, and there is also edema at the insertion of the near the lesser tuberosity. So this is again concerning for anterior shoulder impingement.
And this is a fairly common case. We saw another previous example. We have a severe tendinosis of the subscapularis tendon. We have edema within the lesser tuberosity. We have a narrow space between the coracoid process and the lesser tuberosity, and we've got anterior subluxation of the biceps tendon with increased signal intensity and flattening of the biceps tendon. So I think all of these factors come into play to produce the anterior shoulder pain in this particular individual. So it's actually multifactorial, but a major component of this is coracoid impingement. Now, another form of impingement called internal impingement is often seen with high-performance throwers. There's a lot of controversy to this. This is often associated with GERD, which is glenoid internal rotation deficit. And with this, we're really just talking about high-performance athletes, primarily pitchers and throwers. It's probably due to extreme forces on the humeral head in the late cocking and early acceleration phase of throwing, causing impaction of the posterior superior humeral head against the glenoid, impingement on the posterior rotator cuff, and posterior superior labral tear. So let's look at this. So we're really talking about the throwing athlete. You see this a lot in Major League Baseball pitchers and catchers. So this is the sequence of throwing, which is from Job, from the Curl and Job group, which he kind of popularized. You start with the wind-up, then you separate the hands at the end of the wind-up. You have the early cocking phase, the late cocking phase, and this is what we're going to come back to repeatedly in this part of the discussion, is the late cocking phase. Then you have the acceleration phase where you start putting speed on the ball. Then you release it at the end of the acceleration phase, ball release. Then you rapidly decelerate the shoulder, and then you have the follow-through coming through. So those are the different aspects of the throwing mechanism. So there we can see it. And if we start back here, you can go through the different phases. There's the hands are together here. So that's a wind-up. They're separated at that point. Then you get the early cocking phase there, and then the late cocking phase in this location. Now, actually, all of you play like your baseball pitchers here and get your arm in this location. Try it.
No way. I'm going to leave now, Dr. Cruz.
What?
I have to leave for the procedure. Thanks.
Okay, great. That's fine. Now, if you notice here that his arm is such that a 90-degree angle with respect to the back would have his arm up in this location. He's able to extend it even beyond that. And he could not do this with his other shoulder. This is something that generally occurs around the age of 13 to 15. And one of the reasons why almost all high-level baseball pitchers were pitching at age 10 years and in their early teens. This actually requires both soft tissue and bony changes to the shoulder to allow you to cock your arm in this location. Why is it important? Is because, as we'll see if we go through this, this is where he starts putting momentum on the ball. And then if we follow, there's the next sequence. And in one sequence, he actually goes forward and is actually releasing the ball. So there's tremendous acceleration of the arm from the late cocking to the ball release phase in this location. And the more he can get his arm back, the more arc he has to put momentum on the ball. If you can only get your arm straight above your shoulder, like me, and then you release it at 10 degrees forward, I only have a 10-degree arc to put momentum on the ball, so my fastball may be 40 miles per hour, which isn't going to cut it in Major League Baseball. In order to be able to throw a ball like this, you have to have more than 90 degrees of arc in order to continue to put momentum on the ball so you can get your fastball up in the upper 80s or 90s. So being able to put your arm in this location is critically important for a Major League Baseball pitcher. If you can't do it, you can't pitch. And so to be a Major League Baseball pitcher requires a lot of changes in actually the anatomy of the arm in order to be able to do this. And again, they can't throw this on the left side because they can't put their arm in this position on the left side. I think we're kind of toward the end of our time. Why don't we stop here, and we'll start at this point tomorrow, and then we'll go through internal impingement and how this position actually can produce problems in the shoulder, which can be a problem to deal with. Okay. So,
Thank you, Dr. Cruz.
any questions up to this point? Okay. Thanks, everyone.
Well, you taught them well, John. I have no questions.
Okay, right. Yeah. Okay, no, that's because I'm not clear. Okay, thanks.
Okay.